Today I'm here to talk to you about systemic lupus erythematosus, which is one of the primary forms of a rheumatic disorder known as lupus. The other, which we won't be covering today, is discoid lupus, which affects only the skin, unlike SLE, which can affect the whole body. So like I said, SLE is a systemic autoimmune disease that results in multi-organ inflammation and damage, which is due to the pathogenic autoantibodies targeting the components of the nucleus within the body's tissues. The resulting clinical presentation is varied widely, but the manifesting symptoms are the result of chronic inflammation at the affected target organs. Patients are classified as having SLE if they exhibit 4 or more of the following symptoms. So let's start with a bit of a case study to give you a bit of an idea of what we're talking about, and then we'll come back to it throughout. Selena Gomez was diagnosed with SLE in 2013 at the age of 21, undergoing chemotherapy in 2015, following which Gomez opened up about her condition. It changed her whole life. It changed her morale and ability to function and be on the stage, and in a more indirect way led to anxiety and panic attacks and severe depression. She withdrew from her friends and family. She was so exhausted even her eyelashes hurt. For Selena, remission didn't last long, having to undergo a kidney transplant in late 2017. Here, Selena talks about her struggle and how the transplant has affected her condition.
I had arthritis. My kidneys were shutting down. My mentality was just to keep going. I didn't realize how much it was affecting my body. My kidneys were just done. That's it. I guess I got to the point where it was really kind of life or death. It's really hard to think about or even to swallow, especially now that as soon as I got the kidney transplant, my arthritis went away. My lupus, there's about a 3 to 5% chance it'll ever come back. My blood pressure is better. My energy, my life has been better.
So who does SLE affect? The prevalence and incidence of SLE can differ significantly depending on ethnicity, gender, and disease definition, but is broadly accepted as a rare condition affecting only a small number of the population. The current data on the prevalence and incidence of SLE in Australia is limited. However, the recent development of the SLE registry suggests that 19 in 100,000 Australians of non-Indigenous backgrounds suffer from SLE. While the incidence appears to be on the rise, with overall rates thought to be between 0.9 and 3.1 per 100,000 per year. These findings are consistent worldwide, with similar prevalence and incident rates, with the highest occurrence of SLE found in North America. Evidence suggests that SLE is more common and more severe in Indigenous populations, with more than double as many Native Americans suffering from SLE than the non-Indigenous populations in US and Canada. Similarly, in Australia, the prevalence is 92 per 100,000 in Indigenous and Southeast Asian populations, while survival rates are much lower, as low as 60%. Like most rheumatic conditions, the prevalence of SLE is significantly higher in women than men, for all ages, ethnicities, with female-to-male ratios ranging from 2 to 1 to 15 to 1. Diagnosis peaks around middle age, 45 to 69 years in women, while in men the age of diagnosis has been found to be more varied and typically later in life, between the ages of 40 and 89 years. The etiology of SLE is not well understood. However, it is believed to be due to a combination of genetic factors, environmental factors, hormonal factors, spontaneous events, and immune abnormalities. The interaction between the environmental and genetic factors appear to trigger an immune cascade, resulting in the dysregulation of cytokine and immune cells, specifically T cells, B cells, and macrophages. The strongest genetic association with SLE is due to the presence of rare, inherited single-gene mutations in the complement system. These genetic defects result in complement deficiency, reducing the ability to clear cellular debris. While hundreds of SLE-associated genetic mutations have been identified, their loss in function typically results in only a small increase in patient risk and some aberrant immune responses. However, when an individual carries an aggregate of SLE-associated genetic mutations, they may reach a threshold for which increased SLE susceptibility occurs. UV light and selected drugs are well-documented environmental triggers for SLE due to their impact on DNA. UV light can cause DNA strand breakages, modifying gene expression, forming fragmented nucleic acid particles, or inducing apoptosis. Drug-induced SLE is thought to be due to modified DNA methylation. Hormone levels contribute to SLE predisposition. Expression of prolactin levels is increased in patients with SLE, while estrogen, a modulator of lymphocyte activation, has been shown to increase SLE exacerbations, providing a partial explanation as to why SLE is more common in women. SLE is characterized by pathologic processes that reinforce themselves in the establishment and maintenance of chronic inflammation. Impaired apoptosis and clearance of cellular debris, due in part to the genetic environmental factors that we just discussed, stimulates the release of nucleic acids and their binding proteins. Put simply, the body develops autoantibodies which are targeting the normal intracellular antigens, resulting in an immune response and damage, which then spills more of the nucleic acids which are being targeted to begin with, forming an immune cascade. So let's look at this a little bit more deeply. Following recognition by toll-like receptor 2, myeloid dendritic cells are activated, resulting in the secretion of pro-inflammatory cytokines like IL-6, TNF-alpha, and IL-23, and the activation and differentiation of T cells following self-antigen presentation. The secretion of IL-6 and TNF-alpha limits the activity of the suppressive TREGs, resulting in the upregulation of pro-inflammatory Th17 and IL-17 and IL-23, as well as the activation of B cells in the germinal center. Now, this process is the body's natural response. The problem is that it is occurring in response to self-antigens. To make this worse, the ongoing presence of cellular debris in the germinal center allows for presentation of self-antigens by the follicular dendritic cells. This promotes maturation of B cells and differentiations to plasma cells. The aberrant activation and subsequent production of autoantibodies is maintained by BCR, TLR7 and 9, as well as BAFF and APRIL, which are produced by the myeloid dendritic cells. Complex autoantibodies formed by plasma cells bind nucleic acid components and promote Fc gamma receptor mediated uptake and the secretion of an array of pro-inflammatory cytokines, including IL-6, IL-8, IL-1 beta, IL-10, IL-12, and TNF-alpha. So a whole heap of those inflammatory cytokines that we're very familiar with. Now, both the plasma cells and the plasmacytoid dendritic cells migrate into the inflamed tissue. The plasma cells form LLPCs, or long-lasting plasma cells, promoting increased autoantibody production and immune complex formation, while plasma dendritic cells internalize antigens and maintain the secretion of INF-alpha, continuing that pro-inflammatory state. Immune complexes further activate plasma dendritic cells, NETs, and B cells through BCR-TLR crosstalk, resulting in a feed-forward autoimmune loop among cytokines and neutrophils, initiating amplification of the adaptive immune systems and chronic inflammation. Immune deposition of immune complexes can fix complement in the classical pathway, tagging cells for elimination, leading to tissue damage within the affected organs and a reduction of serum complement levels. So in a nutshell, the clinical presentation is ultimately the result of tissue damage mediated by the inflammatory response to the autoimmunity and immune system activation, along with an excessive abnormal repair mechanism. So we've already had a bit of a glimpse of what the clinical presentation of SLE may be like with the case study. But let's look at it a bit more deeply. The clinical presentation can vary widely, with different organ systems affected, and it is one of remission and relapse. However, the pathogenesis of symptoms is consistent. Tissue damage due to pro-inflammatory cascades, most commonly seen in the muscles, joints, kidneys, blood cells, skin, heart, and lungs. Systemic presentations such as fever, fatigue, and general malaise, as well as weight loss, will affect most SLE patients. Fatigue is not only an indicator of active disease, it's often refractory to treatment, contributing significantly to decreased quality of life, even throughout remission. Intermittent arthritis will be seen in up to 95% of patients. Typically, it will present as a non-erosive symmetrical polyarthritis in the hands, wrists, and knees due to the pro-inflammatory cytokines that we've just discussed, resulting in increasing inflammation and synovial fluid effusion. Acute molar rash, photosensitivity, and chronic discoid lupus erythemosus, which is a subgroup on its own, are the most common topical manifestations of SLE. Malar rash is a fixed, flat or raised rash affecting the cheeks and nose in a butterfly-like pattern. Photosensitivity presents with a rash as an irregular response to sunlight. This is thought to be due to the UV rays damaging the DNA, causing apoptosis of keratinocytes at an increased rate. The kidney is the most commonly affected visceral organ, with all patients showing some level of renal involvement. Lupus nephritis is a common complication due to the deposition of immune complexes within the glomeruli of the nephron, activating the complement cascade and the release of degradative enzymes and reactive oxygen species from neutrophils, causing damage and the death of nephrons. Initially, nephritis can be asymptomatic, or it can present with hypertension or hematuria. Eventually, without intervention, nephritis can lead to acute or chronic kidney disease and contribute significantly to mortality. So if we have a look back at some of the symptoms that Selena talked about, she had nearly all of these symptoms, which, while not always the case, is quite often seen as the disease progresses. SLE can also cause anemia due to chronic inflammation and hemolysis of red blood cells, pleural and pericardial inflammation, seizures and psychosis, and increased deposition of atherosclerotic plaque. Comorbidities in SLE can be as a result of the disease itself, such as CKD and coronary artery disease, or as a result of medications used to treat SLE. Glucocorticoids are a primary contributor to SLE comorbidities, often causing type 2 diabetes mellitus, osteoporosis, and recurrent infections. Where remission cannot be achieved, secondary conditions in the affected organs are common and can cause end organ damage and failure. Diagnosis of SLE is based on clinical symptom recognition and laboratory tests. Classification criteria such as the American College of Rheumatology are often used in practice to diagnose SLE, providing a guide of the classic symptoms and spectrum of SLE. The specificity and sensitivity of these criteria are quite good, but not excellent. We also use anti-nuclear antibody testing and anti-extractable nuclear antigens, which form the standard of serology. These allow for the identification of SLE antibody subtypes, anti-SM and double-stranded DNA, and antihistone antibodies, which are associated with drug-induced SLE, providing guidance on the origin of the trigger. Other tests include complement system levels, electrolytes, kidney function tests, as well as full blood counts and urine proteins, but these are typically guided by the patient's clinical presentation. As we heard with Selena, she ignored her symptoms. This resulted in a significant delay in her diagnosis, at which point significant organ damage had already occurred, highlighting the need for improved diagnosis tools and awareness, as early recognition is associated with improved prognosis due to reduced end organ damage, comorbidities, and thus is associated with a decrease in mortality. Likewise, patients with mild symptoms are less likely to progress to more severe disease and have an improved prognosis. Patients who achieve remission often still suffer with symptoms due to the buildup of damage in the body during active disease, reducing their quality of life and functional ability. Long-term studies suggest that 40% of patients with SLE develop damage to at least one organ. Yet, due to improvements in treatment, 80 to 90% can expect to live to a normal age. So let's talk about treatment and management. The treatment aims for individuals with SLE are to ensure long-term survival, induce remission, and maintain remission where possible. If complete remission cannot be achieved, attain the lowest possible disease burden, slow the disease progression, and prevent organ damage and maintain their quality of life. So pharmacological treatment should always begin with empirical therapy. This is individualized for each patient based on their disease activity, the organs affected, and the severity of the disease. First-line therapy for SLE is hydroxychloroquine, as it is associated with relief of systemic musculoskeletal and mucocutaneous symptoms, reducing the risk of flares. Hydroxychloroquine is also associated with improved lipid levels, which, as I said earlier, are often increased in patients with SLE. Additionally, there is some observational evidence to suggest that hydroxychloroquine can decrease thrombotic events, continued organ damage, and overall mortality, which is a pretty good outcome. The use of combination therapy is based on the severity of the disease and the combination of organs affected. Patients with mild SLE, those with cutaneous and musculoskeletal involvement without any visceral organ damage or involvement, may be treated with hydroxychloroquine only, with or without NSAIDs and/or short-term systemic corticosteroids to reduce inflammation. However, these are typically reserved for disease with severe visceral organ involvement or life-threatening disease. Patients with moderately severe disease, that is, those with significant but non-organ threatening disease resulting in constitution, cutaneous, musculoskeletal, or hematological manifestations, are typically treated with hydroxychloroquine plus a short course of systemic corticosteroids. This is often followed with a steroid-sparing adjuvant such as cyclophosphamide, mycophenolate, or azathioprine to maintain symptom control and achieve remission. Patients with severe or life-threatening disease with major visceral organ involvement typically require an initial period of immunosuppressive therapy to limit disease progression. This is generally achieved with high doses of glucocorticoids as monotherapy or in conjunction with additional immunosuppressive agents. Glucocorticoids remain the first-line treatment of acute, severe flares due to their ability to rapidly modulate systemic inflammation, reducing the organ damage and assisting in disease control. This intensive therapy is followed by maintenance therapy, consisting of glucocorticoid weaning and a decreased dosage of immunosuppressant. Second-line immunosuppressive agents include mycophenolate, azathioprine, and cyclophosphamide. These agents remain second-line, although more commonly used in specific clinical presentations, which we'll talk about, due to their increased toxicity and side effect profiles, and the absence of comparatively improved patient outcomes. The role of biological disease-modifying antirheumatic drugs, or BDMARDs, in SLE is unclear. However, there is growing evidence for their efficacy and improved patient outcomes. Belimumab has shown beneficial outcomes in treatment-resistant patients with active musculoskeletal or cutaneous disease, showing moderate improvements in clinical outcomes in up to 58% of patients compared to 46% with standard therapy, as well as very favorable safety profile. However, there is currently insufficient evidence for its use in active lupus nephritis or renal affective SLE. In Australia, it is currently used as an adjuvant therapy. The evidence for rituximab is mixed and controversial, with clinical studies not showing improved outcomes in heterogeneous SLE patients. However, small observational studies and systematic reviews suggest that it may be efficacious in select patients with refractory disease, such as those with lupus nephritis. Consequently, it may be used as a last-line therapy as a steroid-sparing treatment. The current literature around the management of symptom-specific SLE, other than that of renal and skin manifestations, is limited. However, the selection of pharmacotherapy is typically still guided by the primary presentation and affected organs, some of which we'll go through now. Constitutional symptoms, which are often observed, such as fatigue and fever, are often caused by factors not directly associated with SLE, and therefore, for appropriate treatment, the underlying cause must first be identified. Fever, due to active disease, is rare and is often due to the presence of underlying infection, particularly in patients currently on immunosuppressive therapy. If an infection has been excluded, treatment with paracetamol is indicated due to its antipyretic nature. Fatigue is often the result of comorbidities and complications such as depression, anemia, and sleep disturbances. These can typically be treated using empirical pharmaco and non-pharmacotherapy. Musculoskeletal manifestations such as arthritis and myalgia should initially be treated with paracetamol, and where the response is insufficient, change to an NSAID where appropriate. If the patient continues to experience an inadequate response, conventional DMARDs may be required. Hydroxychloroquine is the first-line therapy for the same reasons we talked about before, with methotrexate and folic acid used in severe presentations due to their high efficacy and ability to achieve and maintain remission. Renal manifestations are treated based on histological classification and disease severity, but typically consist of high-dose prednisolone plus either mycophenolate or cyclophosphamide. These agents are first-line due to significantly improved survival rates and decreased serum creatinine levels when compared with other immunosuppressant agents. If these therapies are not effective in achieving remission, as was the case for Selena, organ transplants and dialysis can become the only option. Additionally, management should also consider the avoidance of renal toxic chemicals where possible, as well as effective treatment of disease states that can contribute to further renal decline, notably dyslipidemia and hypertension. Antihypertensive therapy is guided by standard empirical therapy, beginning with an ACE due to its efficacy and renal protective properties. Similarly, patients may benefit from aggressive dyslipidemia therapy, as evidence suggests it's associated with improved cardiovascular disease and renal outcomes, as it's been found to lower serum levels of inflammatory markers, decrease inflammatory mediators, as well as lipid levels, which are often elevated in patients with SLE. So let's have a look at some non-pharmacological treatment. Now, this plays a more minor role in the treatment of SLE. However, due to significant health burden associated with SLE, psychotherapy is always recommended to assist patients with coping with the impact the disease has on their life. Evidence currently indicates that CBT can improve quality of life, depression, and anxiety in patients with more than pharmacotherapy alone. Avoiding trigger factors can help to reduce frequency of flare-ups in patients with SLE. Triggers such as stress, fatigue, and exposure to carriers of active infections should all be avoided where possible. Additionally, due to the increased photosensitivity associated with SLE and its ability to trigger flares, it is recommended that patients always use appropriate sun protection and avoid significant exposure to UV rays, including those from fluorescent lighting. Subsequently, patients may suffer from low vitamin D levels. It's therefore recommended that patients take a vitamin D supplement, preferentially calcitriol, in those with renal manifestations. Smoking cessation is also important in patients with SLE, as it is associated with more active disease and increased atherosclerosis. So, patients who do smoke at the time of diagnosis should be assisted in smoking cessation and provided with NRT where appropriate. Diet and nutrition and exercise may play a role, however the evidence is not very strong. But the current recommendations suggest that patients should follow a well-balanced diet with isometric and graded exercise. Now let's have a look at some of the monitoring requirements for patients with SLE. So we're going to look at the disease activity, the severity of the disease, any organ complications, as well as the potential for drug-induced adverse events. Specifically, we're going to assess the disease activity using a full blood count in order to identify leukopenia, anemia, and thrombocytopenia, which are common in active disease. Additionally, we want to look at reactants such as ESR and CRP, which are often elevated in patients with SLE. But one thing we do need to note is we want to look at the patient's baseline because these can be generally elevated in patients with SLE, so we want to be able to gauge whether or not it's increased for the patient. Urine analysis along with serum creatinine and eGFR should be examined, as this identifies proteinuria and elevations in serum creatinine and decreased kidney function, which are key signs of renal manifestations. Other visceral organ monitoring should be undertaken to determine if they are affected, and if so, to identify signs of deterioration. This would include cardiac investigations, lung function tests, cognitive and neurological assessments, and other organ tests such as biopsies for the skin. The frequency of monitoring should be patient-specific due to the severity of the disease status, and the frequency of previous disease exacerbations. Alright, so let's talk about some of the limitations to current SLE therapies and what's happening in this space. So the life expectancy of SLE has improved significantly over the last 10 to 15 years due to changes in diagnostic tools and the available treatments. However, it remains significantly lower than individuals within the same demographic. This is due to several ongoing limitations in the management of SLE. Diagnosis is a notably challenging area faced by practitioners due to the heterogeneity of SLE, so the variety of presentation. In addition to the difficulties in disease diagnosis, there are also challenges around the identification of patients at risk of renal and neuropsychiatric manifestations. These manifestations are associated with significant mortality, and early intervention is critical for improving patient outcomes. Current research around the development of a bedside information tool that can rapidly identify these at-risk patients to ensure that intervention is prompt is currently underway, and hopefully then a best patient outcome can be achieved. So despite what is known about the pathogenesis of SLE, which we covered earlier, there's still large gaps in the key mechanisms that initiate and perpetuate SLE. Fatigue is a common symptom that significantly contributes to decreased patient quality of life due to the ineffective nature of current treatments, with research suggesting that despite achieving remission, some patients suffer with ongoing issues of fatigue with no discernible cause. Further research is required so that we can move towards prevention of SLE, as well as identifying additional targets, particularly for patients with these treatment-resistant disease manifestations. However, newer therapies may bring hope of better improved patient outcomes, and the refinement to stem cell and genetic techniques may offer a cure in the future. So now I'm going to go through some of these newer therapies that are coming into the market. So SLE is still undergoing a lot of research and investigation, and there have been several different approaches, with many clinical trials still ongoing in the area of development for new treatments. Some of the targets include aberrant B cells, the JAK-STAT and tyrosine kinase pathways, as well as IL-6, INF-alpha and gamma receptors, some of the ones that we noted during the pathogenesis of SLE. As we discussed earlier, the B cells play a key role in the pathogenesis of SLE, so appropriately targeting this pathway is a logical investigation. Atacept is in phase 2b trials and is a recombinant fusion protein that comprises a portion of both the BLyS and APRIL, which are cytokines responsible for B cell maturation. The current results show that a decrease in disease severity occurs in patients with high disease severity. The JAK-STAT pathway is a series of intracellular signaling between proteins that can result in modulation of immune cell function. So this sounds like a pretty good target. Baricitinib inhibits the Janus kinase enzyme, inhibiting signal transduction, decreasing the intracellular activity, and modulating the activity of the aberrant immune activity. Baricitinib was approved for use in the US in June this year following clinical trials showing significantly higher response rates and improvement. Another one is anifrolumab, which is an INF-alpha-beta targeted monoclonal antibody that has just entered phase 3 trials following a positive response in phase 2. Now this is just a snapshot of some of the research that's going on, and as you can see on the slide, there are hundreds of more trials going on, and they're examining all of these key pathways in SLE. So hopefully in the future we'll move towards finding a cure.